Thank you so much, Jenny. And I was also on during the initial segment, and it's a wonderful program with great participation and question, as we always expect these programs to have. And it's a real pleasure being here, and most importantly, I think with the patients. So I'm going to take from the enthusiasm that Dr. Madhuri has so very well presented about CAR T cells and what they are, how they are, why they are. So the next phase of this is to talk about what results we have so far. The quick key question I'm going to deal with is what is the current state of progress in CAR T and what are the studies and the results, and then Dr. Wij would take over and see what's in future. So there are a number of studies done of various size. By transplant and other criteria, the size is still smaller, but we have good accumulating data. So I'm going to show some of the data um, from one of the major study and then some other medium-sized study to give a feel to all our listeners of why we are so excited about this treatment. So this particular study is called Karma study, and study has been completed. The data is combined, and actually this data is now submitted for commercial approval that we are all hoping will happen in the early part of the next year. So this was a study in patients who had relapse and refractory myeloma, and one of the key criteria currently in most of the study has been that patients should have received immunomodulated drug such as Revlimid or pomalidomide. They should have received one type of proteasome inhibitor. It could be carfilzomib or it could be bortezomib. And they should have received one of the newer antibody that targets CD38. Daratumumab is more common, and the more recently approved isatuximab. So patients who have had this kind of treatment received, they were eligible for this study. And overall, 128 patients have been treated, although initially 140 were selected, but for various reasons, 128 patients ended up getting treatment. And at the process that Dr. Madhuri very elegantly described is where initially when patient is considered now as a good candidate for this study, the first step is to collect the peripheral immune cells. And once the immune cells are collected, it takes around 4 to 5 weeks to prepare this CAR T cells. And during the intervening time, because the patients on this study, as you will see, have lots of previous treatment, their myeloma progresses very fast. So during that time, we are able to give something what we call bridging therapy. We're just going to give treatment so the myeloma doesn't grow out too much and cause any big problem while we wait for the CAR T cells to be produced. And so once the CAR T cells are produced, they get this lymphodepletion therapy, CAR T cell infusion, and then a month later, we begin to measure what is the efficacy or response following this CAR T cell infusion. So in this particular study, our main purpose was how often do we get response following CAR T cell therapy? And as Dr. Madhuri showed, that Mammoth study, patients who have had many lines of treatment, the frequency of response with next line of treatment ends up being between 20 and 30%. So we'll keep that number in mind when we come to the results of this study because there's such a big difference. So who were these 128 patients who went on this study? So these patients, they had 6 lines of previous treatment. So they had 6 different lines of treatment, and 3-drug regimen is considered as 1 line even with transplant. So they had lots of treatment. Most of the good drugs that we have were already utilized before they went on this study. Almost all, 94% patient had transplant, and 1/3 of the patient had 2 transplant or more. Patient's myeloma was serious enough that during those 4 weeks, 88% patient required something to hold their disease while CAR T cells are being made. That just tells us that these patients had very aggressive and progressive myeloma. And almost all the patients had what we would call refractory disease. They were not responding to their last treatment. That was one of the requirements to go on this study. So again, they had what we call resistant disease. And so very advanced aggressive myeloma patients were put on this study. So in this setting, what did we see? The So the response rate in this patient was 82% at the dose that we are hoping to utilize in patient if enough cells are produced. So 82% response rate at this dose of 450 million cell. And if we take all the patients with less dose and intermediate dose, still the overall response rate was in 3/4 of the patient, 75% of the patient. And we compare it with the data that Dr. Madhuri showed, 20 to 30% response rate with anything else. So this is significantly better. This is as if we are treating this patient in the beginning when we see 80 to 90% response rates. And the responses were observed very quickly. In 1 month, patients achieve very obvious response. By 2 to 3 months, they receive a very deep response, including complete remission. So how many percentage of patients ended up getting complete remission? Close to 40% at the high dose level. And that's an unbelievable number in this patient population where we don't even expect CRs to happen very frequently. So that was very exciting part. And if we take all the patient with all the dose levels, still close to 1/3 of the patient had complete remission. And so that's something first very important point, that overall 82% patients respond. Almost 40% patient in this study had what we would call complete remission. Now, we go beyond that and look at now MRD. And there was some discussion before, and we can have more discussion in this session as well. But we are beginning to measure what we call minimal residual disease, where using very sophisticated technique, either sequencing based technique or what we call flow cytometry based method, using this method, we are able to find one myeloma cell in a million. Traditionally, currently, without those technique, we can probably look at one myeloma cell in 100. So now we are able to do 10,000 times more detailed detection. And when my patients are MRD negative, they don't even have one cell in a million. That's the best result we can measure right now. So 75% of the patient who got this complete remission at 40% frequency, 75% of those patients were MRD negative. And so they were really very good deep response. And that's the strength. That's what we are hoping is going to change how we treat myeloma and what we do. And as we see, these responses are sustained to some extent. So when patients get complete remission, the median PF, what we call progression-free survival before patient progresses, the time to that was 20 months. So these are the patient population, as Dr. Madhuri showed in the Mammoth study, that PFS with anything else is 3 to 4 months. Here we would have 20 plus months if you get CR, and if you take every other patient who responded or not responded, the response rate is close to 9 months. And overall survival curve has not even reached the median, but again, it is 19 plus month. And so it's very exciting about how we obtain or see the responses in this patient population. Now, we need to talk about toxicity because responses are good, how well patients can tolerate it. And Dr. Madhuri mentioned that she had treated a patient who was 79-year-old. So this treatment can be given safely, even in older patient population. And so in this particular study, one of the side effects that we look at, and we would discuss at length, is what is called cytokine release syndrome. Now, you know a little bit about it from Dr. Madhuri's talk, and it can be serious, and it can be sometimes extremely concerning because it can lead to mortality with this side effect. However, in myeloma, fortunately, for some reasons we know, some we don't, the CRS is not as severe. So although at a 450 dose, 96% patients got CRS, it's almost that CRS and the response are in some ways connected, because the CRS happens because of a significant growth of myeloma cells, as a growth of the T cells or the CAR T cells when they are connected with the tumor cells. And so that connection is demonstrated by development of CRS. So 96% develop it. However, in most of those patients, except 6%, it is of the lower grade 1 and 2, where it is not life-threatening. And we still manage it, we still treat it, but it's not life-threatening. In 6% patient, it was grade 3, and which is where we have to be careful, consider observing the patients in ICU or in very infrequent situation, they may need some ventilator and other support, but only 6% of the patients, uh, sorry, 3% of the patient, totally 6 patients had this side effect. So it's very small number of patients. And we have methods to treat it. We can give a drug called tocilizumab, which is given here in 67% of the patient, or we can give steroid, which was utilized in less number of patients. So um, managing CRS is now becoming a reasonably standard practice. We have clear guidelines, and a lot of institutions are able to very well manage this. But this is something we and all are working to see how we control and monitor it. The two other side effects we should keep it in mind. So the patient, we know the patients are being managed safely. One of the side effects is called neurotoxicity, where some neurological symptoms may happen. They could be as trivial as headache, but then there could be more of it connected with various organ function dysfunction, patients forgetting something, to developing basically I would say seizure activity. Patients can become unconscious, etc. Again, in myeloma, for some of the reasons which are known and are not known, the frequency of neurotoxicity is much less compared to the other diseases. CAR T cells are available for lymphoma. However, in that situation, that condition, the neurotoxicity is much more higher. Here it is much less. And I think that is important thing to keep in mind. So only 18% of the patient overall develop neurotoxicity. Again, predominantly, except 3%, the neurotoxicity was grade 1 and 2, which was not major issue. And it can also be managed with the drug, with the treatments we have, tocilizumab and steroid and few other drugs that are coming about. The last side effect that one has to keep in mind is low blood counts. And low blood counts are not happening mainly because of the CAR T cells. They happen because the chemotherapy, 3-day little chemotherapy we give, what we call lymphodepletion, and that's required for the CAR T cell to function well. And that treatment causes low blood count, but it's significant. Almost 90+% patients will have some degree of low blood counts. And I think low blood counts is what we know how to manage, but still something to be careful about. Patients can be at risk for infection. If the platelet counts is low, we have to give transfusions and or manage it. But in majority of the patient, this comes up. And I think that's important to keep in mind. Now, what I showed was one larger study. There is another study called CARTITUDE-1, which is also a different type, but also CAR T cell that targets BCMA. It is a little different version because it's called CAR T cell with dual targeting of the same antigen. And this particular CAR T cell, in the early result, when 29 patients were analyzed, the response rate was 100%. And these are the patients who had a lot of previous treatment. So again, the reasons for our enthusiasm and hope for this. And if I put the data together, about 3 reasonable size studies done using BCMA targeting CAR T cell, the KARMA study I showed, CARTITUDE-1 I just showed, and there's another study called EVOLVE study, 128 patients, 62 patients, and 29 patients. And if you look at this patient population, they all had 5 to 6 previous line of treatment here. And they were all refractory to lots of treatment. You could see triple refractory patients, 80 to 90%. So very advanced disease, high risk disease. Somebody had asked a question earlier about extramedullary disease. 30 to 40% patient had those kind of disease. And in this patient population, we'll observe 2 things. One is, if you look at the efficacy, the response rate is 73 to 100%. So between 80 to 100% patient respond when they got CAR T as 6th and 7th and beyond line of treatment. And that's the strength. Very significant proportion of patients are getting complete response. And of that, very high number, 80+% patients are getting MRD negativity. So again, great hope for all this. And then we can see that the toxicity for this is very similar to what I just described for the KARMA study, for as far as blood counts are concerned, CRS is concerned, and also the neurotoxicity is concerned. So that's the strength of what is here. I'll give a couple examples because visual impression is important. And you could see that this has 2 patients treated. on a specific type of CAR T cells, you could see this patient had a big plasmacytoma here, which was confirmed on biopsy and confirmed on an MRI. After CAR T cell treatment, in a short period of time, you could see the lesions has disappeared, and MRI is now just a dot instead of a big, almost a baseball size mass. It has become smaller size mass. A second patient had this huge big plasmacytoma on the head, clearly myeloma as seen by the biopsy. You could see on the MRI, there is this huge big mass in the head. Following treatment, the mass has disappeared in the visual form, and this has become very small one. And most of the time, these results are observed within 1 to 2 weeks time. So very quick response, very deep response. One of our patients I would show, this patient had CAR T cell. Before CAR T cell, the PET CT scan had all these white dots. That's myeloma. It was all the bones had lots of myeloma. The bone marrow showed huge. These all brown cells here are myeloma cells. Within 1 month of CAR T cells, patients' protein had come down to 0, complete response, and bone marrow normalized, and PET CTs can normalize. All the lesions disappeared. And I think this is the very important part to keep in mind: quick response and deep response. And finally, just to tell you that there are lots of good activity happening, number of CAR T cell. I've only put few of the studies which are further ahead. There are at least 10 to 12 different companies developing various BCMA-directed CAR T cells. And as Dr. Madhuri said, there are many other targets that are being analyzed. BCMA is the most promising and farthest in this. So if I just give you the conclusion of what I just told you so far, BCMA is a very good target for immunotherapy, especially CAR T cell-like therapy. And this CAR T cell has a great promise even when used in late relapse patient, 5th, 6th, 7th lines of treatment. Most of the time now, patients should have at least received 3 lines. So the place where we would probably be using the commercial CAR T cell, and we don't know till it is approved, but after patients have received the 3 drugs, the 3 main drugs, the antibody, the immunomodulator, and proteasome inhibitor will be the area where patients would be treated. And because of such a significant response at the late stage, we are now beginning to study this in early stage. And Dr. Wij would further highlight some of these areas, but we are looking at patients after transplant, patients who have not responded well to transplant, patients who cannot go for transplant, or there are studies to even compare with transplant and see, do we need the transplant, or it can be replaced for now with transplant being done at a later time. And these are all very interesting questions that we will answer. I would not suggest any of this out of the clinical study, but these are the good questions being asked. And the critical point for all of us, as you would realize, is that we are getting very deep response. We are almost removing myeloma. So now the task for us is, how can we maintain the response? And currently what we do is we give 1 shot of CAR T cell, do nothing. And the patients have been without any treatment for 12 months, 16 months, 2 years and beyond. And what I hear from them and all my colleagues too, that they're exceedingly happy that there is no treatment being given right now, and the disease has not yet come back. However, it does come back, as we know from some of the data, and our task is to see how we can maintain that remission and mitigate the toxicity. So I think that's our future. And with all these things, I think we are inching towards a cure with a treatment like CAR T cells. So thank you very much, and we'll have discussion in our questions.